Hello, welcome. Hi, my name is Sarah. I'm a lead embryologist from Complete Fertility. Just waiting for a few people to join. I can see the numbers coming up. So I can't see you, but I can see how many are in the participants section on Zoom. You've got a few minutes to make a cup of tea and get really comfortable. And then this talk is typically sort of up to an hour. So I've got some slides to show you, lots of information for you today. And I'm just watching the numbers come up. So if you've just joined, hi, I'm Sarah, one of the lead embryologists at Complete Fertility. Just going to wait until the numbers settle, give it 2 minutes. So sort of a few minutes past 6:30, and then we'll start. So if you want to make that cup of tea or a cup of coffee, maybe a little bit late for coffee, but that's just me, then you have a few minutes to do so. And so I'm just going to share my slides with you now. Okay. Right, there we go. Okay, so today I'm expecting to do the talk for same-sex couples. So if you're not a same-sex couple and you find yourself on here, it's absolutely fine. I would say 80% of the information is absolutely the same. Maybe a few slides in the beginning specifically tailored to that patient group. If you're a single lady or a heterosexual couple, again, as I said, just stay on. Most of the information is absolutely the same, and there is a question and answer function. There's also specific webinars that are tailored to each sort of patient group. So as I said, the first few slides will be tailored towards same-sex couples, but once we're past sort of introductions, everything is the same. Okay, right, so it's we're 2 minutes in, so I'm going to start, I think. Okay. So, okay, right. So I just want to start by acknowledging everyone for being here. I know it is a big step. So you've done the first step of just attending, which is absolutely fantastic. So welcome to all of you. I hope that I am able to answer some questions, tell you a little bit about who we are, and sort of help you complete your family. So everyone's journey is different, their reasons and motivations, but ultimately we all have the same goal. Sometimes we need a little extra help to achieve the dream of creating a family. So as I said, I hope that tonight will help answer some of your questions to help you understand what is involved in your treatment options and the options available to you and the support that we can offer. We will also talk about what COVID means during treatment. So we're all kind of used to COVID now, so I'll just outline that in the end. And there is a question and answer function at the bottom of your screen. So please put questions on there and I will go through as many as I can at the end. And there's also the chat function, but it's easier for me to keep track of the questions in order if you just put it in the question and answer function. Right, okay. So just to give you a little bit of a background about who we are. So Complete Fertility is a member of the Virtus Health Group. So it's an Australian, so one of the lead Australian fertility providers. They have clinics in Ireland, Denmark, and also Singapore. So 48 fertility clinics overall. They have 7 day hospitals as well. So a very sort of prominent fertility provider in the field. We aim to optimize the chance of our patients achieving a healthy singleton pregnancy. So our recommendations are typically to have 1 embryo transferred for a safe pregnancy. There are scenarios where we might be discussing more than 1, but we want you to get to the end goal in the most sort of healthy, evidence-based way. So we offer very high quality evidence-based individualized care. We are part of a teaching sort of hospital, and we have affiliation with the University of Southampton. So there are active research programs, which means that we're at the forefront of everything that's coming out new. And we don't just offer sort of off-the-shelf treatments because other clinics are doing them. So we offer treatments that are well backed with research and data proof. Our main clinic is in Southampton, okay, so where you would come in for any treatments where we need to sort of physically see you, have you in the lab or in theatre. But we have satellite clinics in Portsmouth, Bournemouth, and Chichester, which means that you can have your nurse appointments, scans and things like that in a clinic that's closer to home, depending on where you live. So just to introduce you to our team, so the clinic was co-founded by Julia Paget, who is an embryologist with over 20 years experience, and she's worked in New York and Australia, London, as have I as well. And then our Professor Ying Chong, who is the medical director of reproductive medicine at Southampton University. And those are sort of some of the faces of people, doctors you might see in the clinic. Okay, so just to give you a little bit of background and sort of how much treatment is accessed in the UK. So most people in the UK are undergoing people in the UK are undergoing fertility treatments. It's about 1 in 6 now. People or couples are having children through IVF, and there's a whole list of reasons. We're not going to go through them now unless sort of someone asks me that question. The reasons for treatment have generally changed through the years, and now specifically more same-sex couples are seeking treatment together. And if you look at the figures there on the screen, in 2019. So data, if you look at success rates, we're always kind of a little bit behind in terms of when we have the live birth data, sort of the babies born from IVF. So something to keep in mind when you're looking sort of online at things. So 4% of all fertility sort of IVF cycles are same-sex couples, a female female having treatment with their female partner, and that has increased from 1% sort of before. So and if we look at the donor insemination, about 44% of all donor insemination is for patients with a female partner. Okay, so what to do? So what I'm going to talk about all the treatment options that are available to you. Okay, so there's donor insemination. That's usually the first sort of step in achieving a pregnancy. So the first treatment that would be offered. There's shared parenthood. So I will discuss that with you as well. And then just generally just having an MOT. So finding out sort of your fertility health in general. So if there is unexplained or subfertility there, then we can go down the IVF or ICSI route, terms that you may have heard of before. And again, I will elaborate in the next few slides. Okay, so how can we help you? The HFEA, which is the Human Fertilization and Embryology Authority, they're the regulating body that regulate and license all fertility clinics. They have put legislation and regulations in place to ensure that the legal parenthood is set. So it's all set by the law. A donor is not the legal parent, so that's important to realize that. Your partner is recognized as a second legal parent. Okay, so there's no question. You sign certain documentation. If you present as a couple, then you are both, irrespective of where the eggs or sperm come from. And we'll discuss how sort of the shared IVF journey as well, in terms of the eggs, that you're both the legal parents together. Okay, so when we look at donor sperm, it's very important that when we're thinking about donor sperm is that we get it from a well-regulated and sort of rigorously screened sources. So we do have a sperm bank here at Complete Fertility, but there are also other ones within the UK that we're happy for you to use. And there are a number of international donor banks that you can access. So the the regulation in the UK is quite strict. So donor banks need to comply, and specific donors need to comply with the regulations in the UK. So we would have third-party agreements with banks that we deem are that fulfill the criteria. If there is a specific bank that you want to use that isn't on the sort of the list that our team would provide to you once you're sort of requesting this information, then let us know. We can look into it for you. But there's a wide range and variety there for you to choose from. And I'll just go to the next part. So the price lists are online, so I'm not going to go into a very depth into that today, but they're all accessible online on our website, so you can just sort of search price lists, and it's all there in certain packages and outlines exactly what you're getting. Also, once you come through and have a discussion with your consultant and your nurse, they have a cost of treatment plan laid out, so you know exactly what to expect. So no hidden costs, all there for you to decide on. And the success rates again are online. So something just for you whilst you're doing your research, just go on the HFEA website. Again, that's a very important place. I know that we all do Dr. Google, but if you look at reputable sites and the NHS, HFEA, any of the clinics, sort of reputable clinics websites, you have all the information and the links there. There's a lot of information online, and I just want you to know sort of what to look at. So the HFEA does give you the ratings, the outline, the clinics near you, helps you find a clinic, explains all the treatments for you, and it's a sort of non-biased, and it has everything on there to support you. Okay, right. So the you can have complete, fertility checkups, and everything is definitely confidential, and there is a very robust counseling service. So part of any clinic's license agreement is that they offer counseling. So this is your right to have the access to counseling, and I'll go through that in a bit. Right, so if you're coming through to use donor eggs or donor sperm or donated embryos, you will be coming through to our donor team. So we have a dedicated team that are specialized and have many years of experience with donation and same-sex couples and single ladies as well, coming through to use donor sperm. And also something to mention, it can be a unknown donor. So when I say donor sperm, I mean it's anonymous donor. In the UK, that's regulated so that the unborn child can have access to that information after the age of 18, which I will cover in a second. But also to mention, it can be a known donor. So you can present with a friend, for example, and that friend would also be put to all those tests that are needed to make sure that donation, the sperm cells, are safe. The hereditary information would be gathered from the known donor and any medical history, and then there will be a decision to if that donor sperm is safe for you to use. If anything does come up, it would then be your choice to whether you can use it or not. So that's sort of things that would be discussed with you. So there are lots of options out there for you to consider, and it's just about what works best for you. Okay, so the dedicated team would be the one sort of first point of contact. There's dedicated phone line, and they will provide you with all the information for a donor sperm, give you access to the donor bank, our donor bank, which I'll show you what that website would look like. So you get a sort of special access code. Okay, right. So you might wonder sort of what kind of people donate and who's sort of donating. So as I was saying, we have our own dedicated bank, and the reasons sort of for donations has really changed over the years. So a long time now, the rules are that the donors need to be they're anonymous, but they need to be identifiable, which means that the child, the born child from donation, has the right to find out where they've come from. Lots of research went into this, into the psychology of humans, and then sort of legislation came out about it. So now that the donors know that they have to be sort of they could be contacted by these sort of their children. The kind of person that comes as to donate is basically someone that wants to do something good. They want to give back. They've sort of seen someone they care about struggle to conceive. So all these sort of really nice stories behind a donor. They also write a pen portrait so that the couple is able to read, to give you an idea about what sort of person the donor is. There is a wide range of professions. For example, the information that you will get, sort of what they do for a living, just kind of outlines their features, ethnicity, sort of background, that kind of thing. There is the rule of 10, which means that in the UK, this is well regulated. So it's not the same in, say, America or somewhere else. In the UK, each donor is only allowed to donate to 10 families. Each family could have more than one child. So the siblings has a different rule. So it could be more than 10 children, but these children, it would be 10 families. And this is to sort of minimize, you know, any of the things that you might think about in terms of like the American movies that we sometimes see with 200 children born to one donor, and you might sort of remember the name. I don't remember the name of the movie, but I remember watching that film. So as I said, at the age of 18, so at the age of 16, the child can find out just a few more information, a little bit more information, but at 18, the contact of the donor can be given to the child. Obviously, you can choose whether you want to or not tell the child that they've come from a donation, but if the child or the person at that age now knows, they can seek that information. It's their right. So it's just something to keep in mind. And there is counseling and implication counseling. So there's a whole session that you will have with a fertility specialist in counseling to explain what the implications of using a donor sample and what the implication is to using a known donor and or an anonymous donor, and what that means, and all of that. So just to give you an idea of what the website would look like. So this is our website. So once you've come through and sort of done all the little bits in terms of seeing our consultant, had a discussion, and we have your information, then you'd get a password so you can access the website and look at all the donors that are in-house. Okay, and then if that's suitable for you, that's great. You can select your donors. There's no sort of waiting time or transport or anything. If not, and you want to look at other banks, the donation team will give you that information so you can go on their website. So the purchasing donor sperm from other websites would be up that are compliant, would be up to you to organize. They get shipped in and then you can start treatment. So I would say we would definitely recommend that is put in place. We have these samples here before we start treatment, because we don't want to be sort of ready to go and not have the sperm, which would be a problem. Right, so this is not a picture of a real donor that we have. This is just for the slide. So that is not this particular patient, but just to show you the kind of information you'll have about the donor. There are no pictures, so you might have done some research and found some websites in America have pictures that you pay extra for, sort of childhood pictures, but that is not within the regulations in the UK. So just again, sort of keep in mind what you cannot do and what is regulated. It's very good that we are regulated in the UK, because it means that you know, everything is going to plan and there's nothing to worry about. Okay, and all the documentation and the legalities is sorted for you. Okay. Right, so there's a lot of sort of paths. So no matter who is providing the eggs, you're both, as I said in the beginning, that you're both the legal parents. You could present as a couple, and then we could take the eggs from one partner who is then carrying the child. But then there's also this sort of mutual or reciprocal IVF, where the Some patients both want to be involved in the process in terms of the eggs are provided by one partner and the pregnancy carried by the sharing partner. And so this is something that we can do, and it's sort of quite routine as well. So if this is something for you, again, you can discuss that with our team once you come through. Something that we mention at all our sort of webinars is the egg sharing. So this is a kind and generous act. It involves the donation of half the eggs collecting during IVF process to an anonymous recipient. Okay. So this is an altruistic thing that you could do. It's very generous. And basically what you would get in return is that your treatment would be free. So the clinic would cover your treatment because you would be sharing some of your eggs for a couple that need, or a person that needs eggs. You might think that actually that would decrease my chances of success, but it doesn't if you look at the statistics, because and you may or may not sort of be eligible in terms of the criteria, because it must be quite high prognosis patients, which just means that you're, you know, in the history, in your history, in the likelihood of becoming pregnant, there isn't any underlying fertility issues, and so your chances of becoming pregnant are very high, and the success rate of those eggs are very high, and there is a minimum number of eggs that we collect. So at least 8 eggs so that you would be eligible to share. I mean, I'm not going to go too much into this, but if this is something that you're interested in, again, mention it or call the sort of our team and we can discuss it further. But something that you could also do is the reciprocal IVF and sharing. So you would be donating to your partner and someone else. If this is something that you're interested in, as I said, just mention it and we will discuss it with you further. Right. So for those of you that are that I had mentioned in the beginning, if you found yourself at the sort of you didn't expect this webinar today, from now on all the slides are the same. Okay. Right. So it's just kind of, I will look at your journey in as a whole. So how do I start? Some people are sort of would be wondering. So basically, you can get a referral from your GP, and you say you're trying to conceive, and then your first appointment can be on your through your GP. Your GP can do sort of very basic tests to sort of assess fertility for you. Okay. And then in that sort of initial consultation, so you'll be referred to us, and you can self-refer. So this is just to say in terms of what you can and cannot access through the NHS, and I have a slide on that. So if that's a sort of a question that you have, I'll cover that briefly. And again, if you have questions, ask me at the end, or just type as we go along, and I'll check them at the end, because I know it's hard to remember questions. Right. So at your initial consultation, your doctor will be sort of doing some sort of basic tests just to assess fertility. There might be some further investigations that are needed, so depending on your specific case. As a general sort of, as I said, a sort of a MOT to assess fertility, general fertility. There might be sort of surgery or other medication that might be needed, so that would be sort of dealt with first, and then you can start fertility treatment. Okay. Right, so I'll just show you our lovely nurses. So that's a group of our really nice smiley nurses, as you can see, and some of our healthcare assistants as well. So they're all very experienced staff, really lovely and friendly, nice people generally that we like to work with. So we generally want you to sort of have a nice relationship with your nurse, and we try sort of to have a line of contact through your treatment. So you'll sort of really get to know your nurse well. But then again, if sort of you're not getting along, because we're all sort of different personalities, just sort of mention it, and then I know, you know, it's absolutely fine. We'll find that someone that best fits you. So they're in the team. So I know we're all different. Our styles are different. So, and same goes with the doctors as well. So we're a very diverse team, and everyone's sort of very qualified and really just wanting to help you along your journey. The HCAs are the people that take your bloods. They meet you when you come into the clinic in the recovery rooms through your sort of embryo transfer and procedures. So again, you'll get to know them well by the end of the journey. Right. So just to give you sort of an outline of what to expect and what treatment involves. So we so treatment can be as simple as some ovulation medication. Okay, we need sperm and eggs to meet. So most of the time it is DI, so intrauterine insemination, which is this. So we would either monitor and have a natural cycle where we know that you've ovulated, and then sperm would be will be prepared in a certain way in the lab, whether it's donor sperm or known donor sperm, and then deposited in the uterus at a specific time of your cycle, knowing that you have ovulated. There we give a little bit of drugs as well. And sometimes if that doesn't work, we can then go on to the IVF, which you've probably heard. It's quite sort of the test tube babies, or in vitro fertilization with or without ICSI procedure, which I will show you a video and discuss what the difference is. So so what happens in your treatment? I'm just going to sort of give you an outline to sort of with this illustration here. So you basically, by this time, you have met your consultant, okay, and then you've also met your nurse. So the nurse has gone through all the consent forms, the procedures, given you information, discussed the test results that you would have had, and then given you detailed instructions about the medication and teaching for the injections if you were doing stimulated cycle with the medication that you need for both you and your partner, if that is appropriate. Okay, you call us on day 1 of your period, okay, and you book a baseline scan. You will have all this instructions about the medication, as I said, and it's all written out very clearly for you. Then the nurse that you call will tell you to start your medication. The medication that stimulates the ovaries to produce follicles. This is called the follicle stimulating hormone. And when we are doing the IUI, so the donor insemination or intrauterine insemination, those medications are very low doses of drugs. When we're doing the IVF, it's slightly higher doses of medication to stimulate more follicles, okay? And as I said, if you're having a natural cycle, your own hormones should be able to, or could, if that was the treatment prescribed to you, will produce a single follicle, will grow, and that's the one we would use, okay? So when we're monitoring your cycle, the growth of the follicles grow inside the ovaries. They're monitored and they're carefully monitored regularly using the ultrasound scanning, okay? And normally you'd come in 2 or 3 times a week. What we're looking to see is that the follicles reach a certain size, so 18 millimeters in size, before the eggs are said to be suitable for treatment. Okay, so bigger, that size of follicles indicates that there is hopefully an egg inside that is mature, and then that egg can be easily, or that follicle can be visualized by the ultrasound scan. And that, as I said, we monitor that regularly. Ovulation is then triggered by using a different hormone injection. If we're talking about the DI, we are wanting to see 1 or 2 follicles, okay? If we're doing IVF or the ICSI, we are seeing a lot more. It just depends on how you are reacting to the drugs, okay? And this process usually takes up to 10 to 14 days. Then a final hormone injection is given, which then releases the eggs from the follicle. The average number of eggs, let's just kind of finish the IUI off. So you do some scans, you call us on day 1, you have your scans, you do your injections. When your follicle, 1 or 2 follicles reach the correct size, we then will give you another injection that triggers the ovulation. We do the insemination, okay? If we're doing the IVF procedure, so that's a very sort of, this procedure is similar, like say a smear test, and it's not meant to be painful. It's just kind of a very straightforward procedure and very quick. If we're doing standard IVF or using with or without ICSI, we then will expect to collect, the average number is 10 to 12 eggs, okay? But having said that, we could get 1, we could get 20, it only takes 1. So every cycle is tailored, everyone is different. So it's not necessarily a single specific thing that will happen for everyone. It is monitored and tailored specifically to you. The final hormone injection is given approximately 38 hours before the egg collection or insemination, depending on which treatment type you're having. So this is usually an injection we ask you to take at really late or sort of odd times in the middle of the night, like 11 or 12, depending on the time we expect you to come in 2 days later. So it's about sort of the scheduling of the procedures in the morning. But again, all this will be given to you, all that information. Right, so once you've had your egg collection or you've had your insemination, we would be giving you medication, so progesterone, and this is in the shape of pessaries. There are other forms for that if that's not suitable for you, and this is to support the lining of the uterus, so the endometrium. And then you continue to do that until your pregnancy test and pregnancy scan, hopefully once you're pregnant. So you would call us to let us know. So the home tests are very accurate, so you just do that at home. If we're doing the IVF and the egg collection, then embryo transfer, and then pregnancy test. And what I will now talk about the IVF and ICSI in a bit more detail. Right, so this is the lab team. I'm not actually in this picture, but you can see lovely smiley faces. There's a wide range of skills and diversity of careers there, and it's a very sort of well-equipped, up-to-date lab, which I'll show you some pictures in the lab now as well for you to see. Right, so what we're doing in the lab. So basically the embryologist is looking after the eggs, the sperm, creating embryos and monitoring the embryos throughout their journey in the lab. We put them in incubators, and those are basically environments that mimic the natural environment in the reproductive tract and the uterus. Okay, so you can see that's my colleague Claire that is demonstrating nicely. So this is the microscope. There, everything is on a heated stage, sort of to control the temperatures. The incubators are kept at sort of body temperature, that's 37 degrees, and low oxygen and certain gases as in the natural environment. Something to mention, we use the embryoscope, which is just sort of the most advanced sort of piece of equipment, which is we can use time-lapse photography. So basically the embryos are cultured in an incubator and they don't leave. We don't have to take them out to check them under the microscope, which is great. The incubator takes images every 10 minutes, and that creates a video. So we are now able to see a lot more information about how the embryos are developing. We also have AI technology that can assist in sort of assessing whether embryos have good potential or not. So that's really good, and that is for everybody. So that's kind of our standard culture system in the lab. So there's just a picture to show you in terms of how the eggs are collected. So when we are retrieving eggs for standard IVF or ICSI, this is done under sedation. So there's a consultant anesthetist there that will, so you won't feel anything. There's a very thin needle that goes sort of through the sort of wall of the vaginal wall here. The follicular fluid is sort of sucked out there into the tube, and those tubes of follicular fluid are then passed to the lab. Okay. So once the eggs are collected, this is what an egg looks like, surrounded by supportive cells, the cumulus cells. So those cells are vital for egg and sperm to react together. Okay, so that's a picture of sperm there. They're not shiny, that's just how they look under this specific picture. I mean, this would be a closer idea in terms of also size. So the egg is very big and this sperm is very tiny. But we want half of our genetics from the sperm cell, which is in the head, and then half of the genetics come from the egg. Right, so if we are doing standard IVF, and the next picture I can show you, we would mix, that's the sperms, and that's the egg there, the dark dot with the cloud of cells around. Mix the egg and sperm together and then hope that they fertilize overnight. We expect, whether it's IVF or ICSI, so whether it's the standard IVF or is a little bit more, so it is natural selection, less invasive, and typically with good sperm samples. So with donor sperm, if they freeze and thaw well, we would expect that a normal semen analysis, gone on to the next one, normal semen analysis should be suitable for standard IVF. The sperm will then swim through the cloud of cells and then hopefully fertilize the egg. Whether it's IVF or ICSI, we expect about 70% of eggs to fertilize. Okay, so the percentage of fertilization doesn't increase just by using a different technique. It's just identifying which technique is more suitable for your case. And I'll show you a video of ICSI. So this is when a single sperm is then injected into an egg. So this is the outer membrane here. So and then you'll see that we go into the cytoplasm in the middle. We will then suck out some of the cytoplasm, and there'll be the sort of a gushing to make sure that we're actually broken through the membrane. And then there'll be a swoosh up in a moment. There we go. And then we will release the sperm into the, there it is, there, into the egg. Right. So this procedure is sort of used when the sperm is of, say, low concentration, if the donor sperm hasn't survived the freezing and thawing very well. If, for example, we've had a standard IVF that didn't work in terms of fertilization before, then there are ways to overcome that. So if we need help with the point that is fertilization, then you may need ICSI. If the fertilization step is okay, then that's fine. You don't need ICSI. So that's just kind of what ICSI is, if you've seen that online or read about it. Right, so once we have fertilization, so once insemination has happened, we call that day 0. So that's the day of egg collection. So day of egg collection, you have your sedation, we collect the eggs, and then you go home, and we will call you with updates at certain points. You continue taking your luteal support, which is the pessaries of progesterone. We aim to do a transfer on day 5 of embryo development, which will be the blastocyst stage. Right, so just to talk you through the pictures you can see here. So fertilization, what we want to see is these two bubbles, two round circles there. One is from the male and one is from the female. We can't tell which is which, they're identical, but that's what we would deem a normally fertilized egg. That's how it looks. So we don't know anything about the genetics in terms of just looking at an embryo, whether it's genetically normal or not. But we know the more sort of regular or normal the development is in terms of what is expected, the more it will correlate with potential for that embryo to work. Moving on, so between that's sort of day 1 now of the embryo development, and then by day 3 we want to see anything between 6 and 12 cells. So that's an 8 cell. These embryos are textbook looking, so your embryos might not look exactly like this, but those are really nice embryos, which are common to see. So hopefully we will see nice embryos for you if you're having this treatment. So we can count the number of cells and give you an idea, or the embryos give us an idea of quality at the stage. Then by day 5 of embryo development, so blastocyst. So we were all once upon a time, we've all gone through these stages, and we've all once upon a time hatched out of a shell in this bubble here and implanted. So a blastocyst, if you can see, there are two sort of distinct areas. There's the core, so the inside, and then there are outside surrounding cells. And the outside cells, I mean, I usually think of it as like a football, and the shapes on the outside of the ball are the trophectoderm cells that are going to develop on to become the placenta. And then the core, all of those cells are connected to a core that will then develop into a fetus or a baby. So that's what we're looking at here. And then by day 6 or up to day 8 in nature, the embryo will hatch out of the shell, leave any fragments behind that it doesn't like, and then hopefully this bubble here that has the core there will implant in a uterus. So just to give, this is a video of embryo development. So it's basically what we've been talking about. So that's the pronuclei forming, and then they'll disappear, and then it will start dividing 2 cells. That we're in day 2 now of embryo development, anything between 2 and 4 cells, like now. Then moving on to day 3 of embryo development, we're going on to the 6 to 12 cells. So the cells start dividing. When we approach day 4, the number of cells increased greatly, and they start fusing together. So we stop counting cells, but it's something called a morula, okay? And then you can see there's kind of dimples forming. Then a cavity of fluid starts to form. That's the stage that just after morula and the cavity where we start dividing into cells, for 2 different types of cells for the first time. So that's the first time in our life where we've differentiated into cells that are destined to become sort of the baby. And then I'll just play it back to show you when we start to pop out of right there. If you look somewhere here, yes, there we go. So then the cells will start to break out there, and that's now an embryo that is hatching, and that is the stage before implantation. Right, okay. So something very important to mention. So it is a legal requirement to have double witnessing. It's the same with nurses dispensing drugs, any of those things. There needs to be 2 practitioners making sure that everything is correct and there isn't any mismatches or any mix-ups. So every single procedure in the lab has to be double witnessed, but not only double witnessed by 2 humans, we also have as a 3rd witness the sort of electronic witnessing. So there, your samples will be, or your eggs, your embryos will be labeled and traced and barcoded through the lab. And this is sort of this computer system where, say, if test tube X and dish Y came onto the working area, and that was obviously incorrect, then there will be a large alarm, and everyone will know that we have to sort of stop. But it never comes to that. As I said, we are already double witnessing everything, and we know that we are being monitored as well by the computer system that can trace all the tracks, trace you through the lab, so we know exactly what has gone where. Right. Just to let you know, so as I said, the counselling is a legal requirement for everyone to have access to counselling. You have, with your packages, up to 6 sessions are included in all packages, but if you ever need more, our counsellor prescribes more, so you wouldn't really be required to pay for counselling. It's just if you need counselling sessions, you are then prescribed them, so don't worry there. All couples using any donor gametes have to have counselling, so that is a legal requirement, just to understand the implications of the donation and the gametes that you're using. So that would be a session that will be booked in and discussed with our donor team at the beginning to kind of let you know what is expected. But there are lots of benefits for having access to counselling. So all couples, all single patients coming through have access, and if not encouraged to kind of have a session. It helps, and staff actually. So there were also open door policy for staff. So this whole process isn't easy, and there are lots of different supporting sort of mechanisms that we have. There'll be coping things for you to use for both you and your family as well. So it's just something to consider when you're coming through, to kind of really use all the tools that are available to you. We also have an app, so you may choose to use the app. So basically this was developed by our clinic. It monitors your cycle, it tells you which drugs to take and when, it sends you messages. There's also emotional support and coping mechanisms as tools on the app. It is a research tool, so you log how you feel daily if you want to be part of that research, and hopefully what we're hoping is it will develop over time to learn and be able to detect stress levels, and then sort of alert a nurse to call you when you're distressed. So that's kind of the aim once this app has learnt and developed. But for now, the nurse is programming. If you want to sort of opt in, you can opt out, it doesn't matter, but to have an app that sort of reminds you when to take your drugs and your appointments and so on. Okay, so we also have support groups. So there are online support groups, I think, on Facebook, and they are mediated by our counsellor. So I think it's Facebook. It might be sort of other websites as well. So you can email the patient support at completefertility.co.uk. Also, there's information online, but also just mention it at with your nurse or at your appointment, and we can definitely get you onto those. It is moderated by our counsellor, and there's lots of sort of people on there that are going through your same situation. Also, there is another sort of option, if you're interested, is to have to be part of the buddy program. So if you're interested, you let us know, and so we can match you up with someone else that's interested, who's going through the same thing, so your similar situation, and basically you can take it from there. You can meet up for a coffee, just WhatsApp, whatever. It's up to you. So there are, as I said, lots of sort of different support available to you. Right, so something to mention is also if you need help with your BMI or hormonal imbalance, lifestyle, nutrition, we do have Dr. Katie, who is a nutritionist and GP that you can have access to. So a lot with COVID, a lot of the appointments can be virtual now, online. So that's really sort of helpful if you don't want to sort of keep coming in for appointments, but we're kind of initial consultations a lot of the time are online, sort of face-to-face, sort of in situation like you can see me, but I'd see you as well, for example. And a lot of patients are really liking that. So even going into the non-COVID or living with COVID world, we would still be offering online appointments because they're working really well for everyone, but it's a personal preference as well once those regulations are removed. Right, so in terms of the statistics and looking at success rates, as I said, you can check the HFEA website. So all clinic statistics are on there, all their ratings, their, how they're doing in terms of pregnancy outcomes, and on our website. And it's just something to keep in mind. And then generally, just in terms of expectations, so just generally, fertility, we are sort of not programmed to produce a lot of offspring. And so, if we're talking, if you're feeling like, oh, those percentages are sort of low or high, it's just keep in mind that you can also see what the national averages are, okay, in terms of your expectations. And sort of comparing to sort of fertility in general. So as a group, generally, the outcomes are pretty favorable because in general, it's not subfertility that is causing the not being pregnant. So the outcomes are quite good. So your success rates, if sort of, as I said, that MOT, everything seems where it should be, then there's really good chances that hopefully this will be a positive sort of experience in the end. So sometimes people need more than one treatment cycle to reach the goal. So it's just kind of having that discussion and understanding expectations. Okay, right. So just to talk about funding. So I know that's sometimes a question for lots of people. So same-sex couples must demonstrate a failure to conceive after 10 inseminations to be eligible for funding for IVF. So that means that you'd have to pay 10 cycles of insemination, which is quite expensive. So I know it's sort of, I would hope that rules would change on that. And it's to prove that there's a subfertility there, and then funding could be available to you, but then you have to sort of weigh out the cost of having 10 treatments to just sort of, if after the first 2 IUIs, if they're not working, for example, going down the IVF route. So it does depend on your age, so your personal circumstances as well. Just let us know. So some sort of military funding and things like that might be different. So, and it does depend on sort of where you live. So Most patients can get their first appointment on the NHS, so that if you remember in that little sort of flow diagram, that first referral can be on the NHS, and then anything moving on from there might have to be sort of private. The CFC Complete Fertility does offer 0 interest payments over 12 months, so that's something to consider. If you are interested, just mention it, and we can put you in contact with the accounts department who can set that up for you. Something else in terms of financing fertility treatment. So this is Access Fertility is an independent sort of company, like an insurer. They have relationships with lots of clinics all over the UK and the world. And basically, they offer a range of financial packages that help to reduce the uncertainty of how much treatment may cost you. You pay a fixed fee for a program of treatment, and in some cases get a refund if you don't have a baby. Depending on which package you choose, but there are certain criteria for eligibility and the medical review as well. So keep that in mind. If this is something that you are interested in, you can just visit their website. Okay, so that's something. It's not unique to Complete Fertility, so they do have lots of clinics they deal with, but it's something that we found that lots of people do like to know, like the cap of how much things are spent. It's like sort of insurance for fertility treatment. Okay. Right, so what does COVID mean in my treatment? So lots of questions are as well to do with vaccination. Do I take my vaccination? And the answer is yes, it is recommended to do vaccinations, to do boosters. Can you do them even in pregnancy? There is lots of data now to support that, to keep both you and your unborn child safe. If the second question says there, if you've already, how soon can I start my treatment? Immediately. You don't have to delay your treatment. If you've just started treatment and you've decided, well, I want to do my my jab now, we would say just wait until we know the outcome and then have it. So in that, as I said, those 2 weeks where it's all happening, maybe try not to have it at that specific point, but before or after or once you're pregnant is absolutely fine. And recommended now. And there's a lot of information on the NHS website, on the British Fertility Society website. It's all accessible to you. There are links through our website, and you'll find links on all the reputable sites, as I've mentioned. So the HFEA, the Human Fertilization and Embryology Authority. So they are, as I said, the regulating body. I would really advise you, if you haven't already, to go on that website to help you sort of navigate this sort of world of fertility, because they're the ones that set the law, the rules, and monitor all the clinics. So everything should be on there to help you navigate. Say there's a lot of treatments available out there. So things like sort of different add-ons. Is this, will this sort of make a difference? Are these proven by science or not? All that information will be there to help you decide. Just coming to the end of my talk now in terms of the slides. So typically before sort of COVID, you'd be in the clinic and we do a little sort of virtual walk round. I've got pictures to show you the clinic, and then I'll sort of start going through the questions. Just kind of some of the reasons why you might choose Complete Fertility, and also just a sort of a summary of things that we've covered today. There are sort of active research programs. So if you're interested in to be part of these programs, you might be asked with consents and things if you want to be included. Right. So that's just a waiting area there. Some of our staff demonstrating they're sat there, so don't worry, those are not patients. So my colleagues walking around the corridor. So the clinic was refurbished when it was acquired by Virtus in 2018. The clinic was established in 2011, and we're now 2022. So we've been private for a few years now. just some pictures from the lab. That one you've seen before, and it's this is the ICSI, so the rig or the big microscope where we do that injection process. This is what it looks like, and that's the dish that has the egg and sperm. This is the frozen sperm. They're in big tanks. They're frozen under liquid nitrogen at very, very, very low temperatures, extremely cold. You see my colleague in her protective kit there. So these are the consulting rooms and also sort of private room if you require that you just mentioned, and that can be booked for you. But otherwise, you're in recovery room, which is really lovely and light with big windows, and sort of you have one of these beds and sort of curtains around you. You're not in the clinic for very long, so those procedures, even under sedation, you might be here sort of by until midday, and then you're allowed to go home once you're recovered and you've had a nice cup of tea and some biscuits. Right, so this is the procedure room, so where we do the egg collection. There is a door to the lab here, and you can sort of see what's happening in the lab on the television up here, and the scan machine when you're having your embryo transferred. Typically, every time we have a webinar, there's always a little sort of thank you in there for attending. So the offer at the moment, but just quote that you have been to the webinar, and we have a list of your names that have registered anyway, but just mention, and then you get £100 off the donor's sperm. So that's something to keep in mind. So thank you very much for being patient with me today. I'm just going to go to, I've got some questions, which is great, and thank you for sort of listening. Okay, so just bear with me. I'm just going to sort of go through them and answer as best of my knowledge. Okay, so the first question, how early should we get in contact? How many months before we want to start treatment process? So I would say, so contact us when you're ready to start. So basically it all depends on your cycle, so your period. Okay, so say you contact us, you'll know yourself if you are having sort of regular cycles, and if not, that's fine. That's what we're here to do, is find out what's going on. So you contact us kind of around the time you feel like you want to start. And so if that's the question, is there a waiting list to start or a long lag time? It shouldn't be. I would say give it sort of a couple of months just in case, but you should be able to access and get booked in with a doctor kind of straight away. Okay. Okay, I'm concerned about the sperm donor selection process. What are the criteria for sperm donor selection? Other than screening for genetic abnormalities and STIs, what about medical history? If a donor were, for example, to have an identical twin who has cancer, what would he be able to donate? So no. So if you have cancer in your family, so anything. So I'll just amend that statement a little bit. So anything that's late onset in life, so Alzheimer or dementia, things that happen to us an older age, isn't considered to be hereditary unless it is something that is. So anything hereditary, that person wouldn't be eligible to donate. So it's very, very kind of meticulous, strict criteria for anyone to be able to become a sperm donor. It is a very sort of big decision, and I kind of completely understand sort of where your questions are coming from, but that's what our donation team would be able to sit with you and discuss. And this is exactly the kind of thing that the counselling, so the implication counselling, can talk to you about. But there are, as I said, strict criteria. So any genetic, anything genetic that comes up in those tests, then that donor would be rejected. All the Hep B, Hep C, all those kind of screenings, the samples are quarantined for a specific amount of time. So for example, HIV and things that are done, and hepatitis C and B, and other lots of the list is very long. They're done at sort of certain intervals to make sure that nothing sort of has developed since that donation. Okay, so anything in the medical history would be flagged up, and that would be, so if someone has an identical twin that has cancer, that would make them unsuitable. Okay. What help can you get through the NHS? So and let me, same person, just I'm going to read the next question in case it's related. If you have, so if you have pre-existing issues such as endometriosis or polycystic ovaries, would the process be different at all? Is there anything else that we would need to do? I'm guessing that's separate to the funding question. So in terms of the funding, everything is very specific. So it would be worth having an initial consultation, because we have dedicated staff that can put in an application for you. So if there's any underlying issue that that makes you subfertile, then that might change your application or your scenario. If we are a same-sex couple with no underlying fertility issues, then that's when funding so far is that we have to prove subfertility by doing 10 cycles. So it's very important to look at. So things that can be done under the NHS, so such as if you have endometriosis or any of those things that need operations, that could be done under the NHS, because that is treatment for you, unrelated to, it may be unrelated to wanting to become pregnant. Okay. The process is similar, so it's very, polycystic ovaries is a common thing. So you know, about sort of 1 in 3 of us have it. So it's not, it is pretty sort of routine. And it would be that you might need the IVF to be able to collect the eggs safely and monitor your cycle. So that's exactly what the consultant would be going through. So it might be worth having that initial consultation. Initial consultations, or even, does not tie you into having to have treatment. So you can have an initial consultation in any clinic and then decide that you want to go somewhere else, or you know, you're not ready for treatment. So it would be a good idea to start, have that, see your GP, get referred to the specialist, the consultant, and then once you have been referred, the good thing about here, for example, is that it's sort of a secondary and tertiary care, which means that if you need the operations done, we're in the hospital, so you can have those under the same sort of blanket and the umbrella rather, and the doctors can then and nurses know how to follow you up and get you through for that fertility treatment once those issues have been addressed. And then pick the sections that can be covered by the NHS and the things that might not be covered under the NHS. But it's very tailored, specific, so you'd have to come and they would sort of look at all of your case and find out what can be funded or not. Right, next question. So how many times on average would you need to attend Southampton with an egg sharing IVF treatment? We're based in somewhere else and wanted to ask how much of this process would be monitored by local midwives. Okay, so once you are pregnant, then you are then back into the system, you know, like anyone who's fallen pregnant. You go to your GP and into your local service. So you would have to attend the, so most of it, as I said, can be done online. If you have a satellite clinic that's closer, then you could do your treatments in terms of the scanning, the monitoring there. But the day of egg collection and the day of embryo transfer would have to be in Southampton. Okay, so you can organize it with your nurse, most of it to be virtual, and we just try to get it to minimum. You'd have to come in, say, to do sort of some blood tests, but you could organize that locally or get that through your GP if there are certain tests that you can get done locally. So we can bring it down to a minimum, but that's something to discuss. But your actual egg collection date and embryo transfer, or if you're doing IUI, so the insemination date, you'd have to come in, physically be in the clinic. So I hope that answers that question. Do we get to see the time-lapse video, how our embryos are developing? Really nice question, thank you, because I'm an embryologist, so I like that. Right, so typically, so the purpose of the time-lapse video is for diagnostic, for us to use as a tool, okay? But the footage is available for you. So if you want the footage, you can just request it and we can send it to you. The files are very big, so it's not sort of able to, we are not able to send them in an email, but what we do is use, say, a website like WeTransfer or Transport, and then you can have a link to access it. Typically, our recommendation would be to wait once you've had the baby or you're pregnant to have the footage, but that's a personal choice. So it's just about how you feel about it, but definitely you can. So it's not a routine where we would give everyone, we give you a picture of the embryo at embryo transfer, but if you request the time lapse, we can send you a link and you can access it that way. Do you, next question, so do you have any HFEA results for same-sex couples, or is the stats you showed for same-sex or inclusive of all patients? So I think the only stats, did you mean, or is the stat you showed? I only showed one statistic on this presentation, and it was specifically to do with same-sex because it's donor insemination. It could mean donor insemination could be single women having treatment as well. So that would be categorized in that same category. Let me just, oops. Just find that slide that you were mentioning. And then click. Oh, that didn't work. Okay, trying to be clever there, didn't work. Right, so so the stat here that says 27%, I think that I can remember, is for donor sperm users. Okay, so it could be a heterosexual couple using donor sperm, could be a same-sex couple, or could be a single patient, a woman. There are statistics on our website to do specifically for donors and recipients as well. The let me just trying to find that slide. There we go. So it's donor insemination, okay? And if we, yeah, right. But typically, so same-sex couples typically, so because most of the time they've got good prognosis, so good outcome, or good in that percentile if your age is sort of under 40 and all of that, and there's no underlying subfertility, it's a matter of eggs and sperm meeting. So there's usually good sort of good prognosis. So we can, if you want to look at our website, there are results on there for you, and then we can, once you are at the clinic, or if you just call us, we can go through specific success rates with you. Okay. Is there egg sharing criteria information available? BMI, medical conditions, etc. Okay, so the best way for you to get this information is to call our donation team. They can go through, but there is specific BMI and medical criteria. Okay, but the best thing, because it's very sort of specific, is to call the ovum donation team and to get them to just ask you the questions and go through everything with you. Okay. Next question. So there is a maximum BMI restriction, okay, and that has to do, depending on the treatment that you're having. So generally, the higher the high BMI, so for example, sort of over 30, it is linked to lower sort of fertility. Okay, so we are able to sort of help with that, and especially if you're having sedation, it's also a little bit more risky. So it's something to consider and discuss. BMI really does come into play if you're going for funding, because there's very strict criteria in terms of the limits of BMI when it comes to NHS funding. But it's something to consider and discuss with your consultant, to like, where are you in terms of on the BMI. Also, very low BMI is not good. That's also not good for sort of fertility as well. So it's just kind of being healthy, and what healthy means to you might be different, and that's why it would be a good idea to talk to a doctor about it, or a nutritionist. So I think I've answered this. How often do you have to go into the clinic during an IUI? So typically you have to come in. So you have to come in to, if you need to do blood tests here, all of that. But lots of the appointments are virtual, and also, so you'd have to do the actual procedure itself. But it is worth just discussing it at your initial appointment, which are nowadays online, and then just to see exactly how often. But in terms of, sorry, you also need to be scanned. So for those 2 weeks, once you start, you get scanned 2 or 3 times a week. So whether there's a clinic closer to you, instead of coming all the way to Southampton, if that's too far for you. So yes, you do need to be monitored so that we know when you're ready to go ahead. So there will be a time, say 2-week period, for example, that you'd have to, you'll have a few scheduled visits, okay? But maybe something you can discuss with the nurse, but that would be the same in any clinic. So we need to physically see you and be able to scan you and know when you're ready. So, okay, so do you only accept UK donor companies? Nope. So not only UK donors, there are a few international ones, like the European Sperm Bank, just at the top of at the top of my head. So it's just worth, we can give you the list of the donor banks that are accepted. And the reason is that the restrictions in the UK, the 10 family limit, the information that's provided about them, the way they are sort of screened, all of these things have to be UK compliant. So that's very important, that they all, the banks that we use have to abide by the UK rules. Otherwise, the clinic would lose their license because it wouldn't be safe for the patient. So it's all of these things are in place to protect you, the patient. If purchasing an IUI complete package, what would the additional cost be for further rounds if it is not successful? So every package, if you're looking, so I don't know the price, the packaging off the top of my head, but if you're looking at one IUI package, that would be that IUI treatment. If it's not successful, then you'd have another IUI treatment, okay? So unless you go for a certain package that states that it's more than one treatment, okay? But one IUI, an IUI is a treatment, okay? Yep. Do you have facility for storing sperm for future treatments? Yes. So we have a cryo bank. So those tanks you saw my colleague taking sort of liquid nitrogen containers out. So once if you choose a sperm from a different bank, for example, you can store it here. So the rules so far up till now are up to 10 years for storage. That may change. It was very topical in the news in the last few weeks. So that might increase. And in exceptional circumstances, so we freeze eggs, sperm, and embryos. In certain situations, if you have underlying subfertility, for example, if you've had, or anything that will affect your fertility, like chemotherapy, for example, you could be able to keep your embryos or eggs up till 55 years. But those are assessed every 10 years interims. Okay, so we check. You have to get a doctor's note or assessment every 10 years to get that 10-year extension, but that might change in the near future to be more than 10. But as it stands, regular situation, up to 10 years. Okay. Is it relevant genetics information shared about donors, such as family history or health conditions, and particularly neurodevelopmental deficiencies? So as far as I'm aware, so so nothing, nothing is shared. It is anonymous, okay? But so we do get all the screening, and everything needs to be negative. If there's anything that is of any concern, then that person would not be suitable to be a donor. That's why it's very important to have a regulated donor, or have a known person, known donor friend, to come through the process of a donation through a clinic, because everything in that the family history, and it's quite a long process and a big commitment from the donor as well, that they would have to attend up to sort of 9 times the clinic before they can be signed off to become a donor. So it's not something that is an easy process to do. And once the donors are screened, medical history, all the genetic tests, blood tests, everything is checked. So what happens if the minimum number of eggs aren't retrieved for egg sharing? Very good question. So you would be, so within the criteria, you would be, as I said, you have a good follicular ovarian reserve, and you'd be expected to do well. If as we're all different and anything happens and we can't sort of predict things, if we don't get enough eggs on the day, that's it, you have your eggs. So if you don't have more than 4, you will not share, okay? You will keep your eggs and also not get charged, okay? So that embryo, those eggs will be yours, but everything up till that point, we will, we will know that you are either suitable for that criteria of sharing, meaning that we expect that you do, that you have a good reserve. So egg sharers need to be under 35. There are, as I said, certain criteria that you have to fulfill. And once you do, we know that it's more likely that you will have more than 8, because the average number of eggs collected are 10 to 12. If less, as I said, then your treatment isn't jeopardized at all, and the recipient cycle will be cancelled. Next question. Lots of questions. So I'll almost to the end. I think I've got another 4 or 5. If you partake in IVF egg donation program, are you able to access free IVF until you get pregnant, or just 1 round? Egg donation program. I'm going to assume that by egg donation program you mean the egg sharing, and yeah, so if you're pregnant and you want another round, that's proven fertility, so that makes you even a better donor. Okay, so that means that you have proven fertility, so we know that your eggs are good, so that is more attractive, okay, to the to be used. So that's good news for that question. What is IUI success rate assuming normal fertility? So the normal success rate, so an IUI, so we had said 27%. Just keep in mind normal conception. So each egg has less than, I'm going to say 5 or 7% chance of working. That's just how we are. Not all of our eggs are programmed to work. When we say, so just generally, we're saying around that 30% mark of with IVF is that sort of in line with natural conception. So if we're doing 1 egg at a time, or 1 or 2 eggs with the IUI, a 27% is the sort of the success rate. So it's not uncommon to have to do a procedure more than once. That's how, say if you think couples will be trying for several months before they fall pregnant, so it's the same. All we're doing is we're trying to achieve that pregnancy quicker. With IVF, we are doing say on average 10 eggs, so 10 months in one go, and then again 10 months in one go, trying to reach that egg that was always going to work, because as I said, most of our eggs, just genetically as we are as humans, not programmed to do, not always programmed to be a baby, and those very few that are genetically normal, that the egg and sperm react and together in the right way work. Right, next question. We are interested in reciprocal IVF. Are both partners allowed to attend all appointments and procedures? Okay, so yes. So you are attending together. So this question might be coming from around the COVID time. There were times where hospitals, people weren't allowed to. I know that's caused a lot of upset just generally, just for all of us trying to go to an appointment by ourselves. So it was to decrease footfall, but now that has been sort of eased a little bit. And then, so there are certain procedures where your partner is definitely encouraged to come with you. And now when restrictions are easing, your partner would be able to attend everything. The only thing that I think I hadn't mentioned is that in terms of the COVID, what we're doing is you'd have to, everyone attending the clinic needs to do a lateral flow to be negative, to prove lateral flow negative test when you come in for not the blood tests and the consultations, but when you're coming through for a procedure. So if you're being in the theatre or near the lab, so both partners, both people would have to do to do a lateral flow test. So staff were doing ours twice a week, and we're still continuing to do that. So we're not changing that, and all the COVID measures are in place still, as sort of we've all become accustomed to. So what is success rate of IUI, which I think I've re-shown the slides, that's okay. I'll move on. In the same way with donor sperm info, can you be seen, one second, in the same way, sperm donor information can be seen by the child at 18. If your donor eggs, what is the rule? This way, da, da, da. Okay. Any offspring, any person, so the right of a human born from donated gametes has a right to find out their origin when they're 18. Parents might not tell their children, they might never know, but if they do know, then it is their right by law to find out. And that, so I can't sort of remember specific dates, but pre a certain time, all donation can be anonymous or not. And they found that there was a lot of sort of issues with then people born to donation wanting to know where they've come from. So the legislation has changed to that you are identifiable after that person is 18. These are all the things and the implication counseling. So there will be a huge list of things that you know, we aren't aware of, or we haven't thought about. These are the things that we would discuss. You would discuss with the counsellor, and all the things to keep in mind with that. As I said, you can have initial consultations and go through, have counselling, and these things are there to help you make these decisions. And then if you decide that it's not for you, then that's your decision, so it's fine. You're not sort of any obligation to keep going with a specific treatment. If a donor donates to different countries, can he create more than 10 families? Very good question. So the 10 families rule is within the UK. So those donors that are coming in from abroad, yes, they will have more families abroad, but they're only allowed to have 10 family slots in the UK. Okay, so that is, again, it could be a plus or minus for you, but a plus to UK donors would not donate here and there unless that particular person is going around the world donating, which is unlikely. So yes, that, to answer your question, say the European Sperm Bank or an American bank, there will those donors are have other donations criteria in that country. So the rules are different. Are you linked to any sperm banks that can provide photos from other countries? No. So that it's just not a regulation in the UK. Okay. So the photos also will be of baby pictures, and that's one particular American bank which charge you extra to see pictures. So that's not, that kind of gimmicky thing is not something that is advocated in the UK. So it's not sort of encouraged. So I can't think of anything that I would know of to have sort of picked photos of the donors themselves. You get kind of an outline of the criteria, the sort of hair color, eye color, height, profession, the pen portrait, things like that, about the ethnicity, about the donor. Right, I've come to the end of the questions. So if no one else has anything they want to ask me, So sorry, it has gone on a little bit longer than, oh, there's some things in the chat. Okay. Let me just see. I'll just skim quickly. There's about 7 notes in the chat. I'll see if there's anything that we haven't covered already, because we've kind of really gone over time now for you. So I'm sorry that I've kept you so long. Right. Okay, if using a donor sperm, does the counseling need to be done prior to insemination or at any point during the process? If prior, how long is in advance should we plan to organize counseling? So counseling is like step number 2, I would say. So 1 would be to contact us once everything's in place. If you are going to reserve donor sperm, you'd have to have the counseling appointment. It's just a consultation. So it's kind of a slot appointment on a given day. So it's not going to take up too much of your time. If a same-sex couple wish to both carry a child at the same point and would like to use the same sperm donor, how do you manage ensure that there will be enough sperm for both? Okay, so good question. Cycles are different, so trying to synchronize your cycles might be so there are it's a good idea to both want to carry pregnancies at the same time. Again, you might just want to think about in terms of sort of having a newborn and going through that process and both being pregnant and your support person being pregnant as well at the same time. So maybe staggering it one after the other is something to think about. But if you're thinking the same treatment, that's something that we can discuss with you if that's what you want to do. So it's tailored to you specifically. Whether the eggs, whichever person the egg is harvested from, you're both registered as a couple, so you can both use that donor sperm or eggs and embryos from that same treatment cycle. If there are any embryos left over, those embryos can be frozen and transferred in another cycle to the partner that hadn't had the first round. So we can talk about that and just about the logistics and things for both of you. And also just knowing if there's enough sort of embryos, I think it's not about the sperm, because sperm comes in millions of cells. It's about having enough embryos and whether just having it one at a time, because but again, we can talk about that and do what is best for you. Yeah. Is there an age limit or a maximum ideal age to have the best success rate with egg harvested from IVF? So the gold standard is under 35. Just if we're going to, just to go on your best success rates. Okay, so we're just biologically formed to have children at a younger age. That's how we are as women. But up, and I would sort of 36, 37, 38. It's a sort of, again, another age group, so there's good success there. 30, 39, I think a little bit less, and then over 40 is another category, so 40, 41, and then over 43, very low success. And that's just how we are generally as women. That's how we are programmed genetically. And it's just worth looking at the statistics on our website or generally on the HFEA website to get sort of an idea of how age does impact our fertility, okay? And the percentages, but there's definitely good success under 40, reasonable within 40, 41, and then over that, it just depends on sort of what you consider successful. So if you are over 43, for example, you can have donor eggs, and then your success rate would be as the under 35s, for example. What is the benefit of initially going through GP referral compared to just booking an appointment directly with the clinic? So the GP referral idea is just so that that initial consultation can be covered by your GP, if in terms of the payment for that appointment. And there are some preliminary tests that can be done through your GP, like blood tests and so, but you're definitely able to just refer yourself to a fertility clinic and get the process started. Is the requirement of 10 self-funded IUIs the same across the country, or does it vary? So I can't really, I'm not quite sure to answer that question, but I do know that funding does vary from one area to the other. So you're right in that. So it is always worth checking, and that is something that can be checked by your consultant at the initial consultation. As I said, we have dedicated administration personnel, people that will be able to look into your queries and ask the CCGs your specific area if needed. So typically what I'm quoting is the Hampshire area. That's kind of what we most of the time. And then last question. If you choose a donor sperm, but they only have a couple of families left to donate to, can you reserve the donor for another round if you wanted to go through IVF again? Okay, so that's a really good question, and I'll just clarify. So it's 10 family slots. So the donor would have deposited and have lots of vials. So it's not the number, it's not 10 portions, it's 10 families. So it's then once you have a pregnancy slot, so you've reserved the family slot and you have a child, then any sperm that you are then purchasing or reserving will then be called sibling sperm. So then you can go on and have as many treatments as you want, as long as that donor has extra available. So if it's worth asking, once you have choose a donor, is there good availability of that donor? Because it could be it's come up to its say you're the 10th slot and there's not so many vials available, and so in that scenario it might be worth reserving more than one unit for that same donor. So typically we use one straw or vial per treatment. Our recommendation is to have a backup one as well in case we need that for treatment. But yeah, it's just about each individual donor, but it is interesting or important to your question is really good. It's just to clarify that it's not 10 portions, it's 10 slots. And then each once you have a slot, you'll have access to as many treatments as you like, depending on whether the donor has enough samples available, which most of the time they do, but it's worth just having that idea of how many treatments you might want and perhaps reserving them at that starting point. Right, so thank you very much. It's been really exciting being with you today. I hope I was able to I hope I was able to answer all of your questions, and I thank you for the questions. It's been really exciting for me, and I'm engaged with you. Please give us a call if you want to speak to myself or any of my colleagues. We're really happy to answer questions over the phone. But if you are looking to anything specifically to do with donation, it is the donor team that would be the best people to help you. Thank you, good night, and goodbye.